Alright, you guys, I'm going to continue with gastroesophageal reflux disease, also known as GERD. Sorry, I'm kind of in a more public place, so people are going to just think I'm really funny talking to myself here. Anyway, what is this? This is the backward movement of gastric contents into the esophagus. So for an etiology, this is where, for some reason, this pyloric sphincter here, which is at the top of the stomach, it is either relaxed abnormally or things in the stomach are being compressed, which is allowing stomach contents to move up into the esophagus. So other common causes would be during pregnancy. We talked a lot about this in nursing or in Unit 1 and how that can happen, and progesterone relaxes the pyloric sphincter and everything there. So for assessment, people are going to complain that their chest is on fire, kind of a feeling. Epigastric pain is what we call it. It's that, place, that pinpoint kind of place in the chest, can be kind of a dull aching. It is, because it is kind of a chest pain, this gets messed up with, an actual cardiac event sometimes, where I've actually had it where a patient in the waiting room has, coming in for what he thinks is really bad GERD, and turns out he's actually having a heart attack. So it is not uncommon for something like that to happen, but it is rare. Usually people, when they get this, we try a treatment, and if it works, then we know, it's probably not cardiac. And that's why we don't have, flocks of people going to the ER for this. For diagnostics, a lot of it's going to be symptoms and, does the treatment work? Otherwise, they can do an endoscopy where they, take the camera down the tube and they can actually see the erosion that might be happening around the esophagus from the stomach contents leaking up into that. For treatments, antacids will work well, Tums, Rolaids, that kind of thing. If those aren't effective, then we go to those H2 receptor antagonists, famotidine and ranitidine. And then if those aren't working, then we can go on to PPIs, as proton pump inhibitors, like I had talked about with the gastritis. So, and those really, research says they should only be used, 3 months at a time. We see people with long-term PPI use. The moment they go off of it, then, the heartburn is back. So, and we know cancer risk goes up if we allow it to continue to have that stomach contents getting up into the esophagus. All right, next we're going to talk about ulcers. So ulcers, these are a break in the mucus lining of the stomach and or duodenum, which is that first part of the intestine where it comes into contact with gastric juice. So etiology for this, one thing I want to talk about a lot here is something called H. pylori. So I'm going to type that into here. So that is a type of bacteria, and it can be part of the normal flora found in the stomach, but if it grows out of control and gets into the lining of the stomach itself, past, the protective barrier, then that becomes an issue. So we really look at, does this person have H. pylori? And if it does, then we can treat that H. pylori and get it taken care of. Other risk factors, we're looking at NSAID use, cigarette smoking, aspirin use. Are they on other blood thinners, like warfarin, Plavix, things like that could cause, increased bleeding and that kind of thing. And if we do have an upper GI bleed, we're kind of think of those assessment findings that we would find with that, what does stool look like? What does the vomit look like? Things like that. Anemia. Diagnostics, again, we're going to do an endoscopy in order to see and visualize the ulcer and see how bad it is. If there is a perforated ulcer, meaning it's gone all the way through the stomach lining, patients will have a very sharp abdominal pain. They will often be diaphoretic with a rigid board-like abdomen that is either filling up with blood, pus, air, something like that. Oh, treatment. I guess I moved on from the treatment. So if the treatment is, if it's H. pylori that's causing it, then the treatment is going to be giving antibiotics to treat the H. pylori. If it's not, then, we talked about like sucralfate. So sucralfate is that Carafate can be used to help coat the stomach. That's the one that has to be drank before meals and at bedtime in order to protect the stomach. Okay, we're going to look at a surgical treatment, which is a gastrectomy. So why would a gastrectomy be done? Gastrectomies can be done, in the case of cancer or some other stomach issue that might be going on that requires a surgical removal of the stomach. So a gastrectomy, this is surgical removal of the stomach. It can be a total or a partial. It's typically the distal half to 2/3. So nursing care, I have some nursing cares listed here. So these people will have to have an NG tube placed. We're going to have to keep that stomach empty. So notice I have it here, decompression for suctioning to keep that stomach empty. And then it's going to be, intermittent suction, right? Continuous suctioning. Assessing color, amount, odor of gastric drainage, noting any changes, the presence of clots or bright red bleeding, notify the nurse or doc if any of these changes occur. We're going to be monitoring bowel sounds, making sure things are still moving. We're going to be measuring abdominal girth, looking at, are we having an increase in size? Do we have internal bleeding or gas or something kind of inflammation building up in there? These people will have to have an IV site in, so we're going to be assessing that. Oral foods, depending on how much of the stomach they take out, this progress can be very time consuming. Sometimes it's like starting out with 1 ounce every 8 hours. I mean, it gets to be pretty intense on how much they're allowed to put in their stomach, and it's going to be just a little bit of clear liquid, progressing to full liquids, and then frequent small feedings of regular foods. They do not want the stomach to get stretched out at all, so it's to keep it more on the emptier side. Monitor our bowel sounds frequently. We know that we begin discharge planning and teaching on admission. So teaching about infection, signs and symptoms, fever, tachycardia, diaphoresis, chills, things like that. Diet instructions, they're going to have to follow very strict diet protocol, worry about things like nutrition, right? Because if they're only able to take in like an ounce, every so many hours, we really worry about the nutritional value that they're getting. Dumping syndrome. So dumping syndrome is when food goes right from the stomach and into the small bowel. I'll talk about that coming up here. Postprandial hypoglycemia is possible, whereas after they eat, their blood sugar drops. And then pernicious anemia, which will follow in a unit coming up. But pernicious anemia is when there's not enough vitamin B12 in the system for red blood cell production. So complications, dumping syndrome. This is food dumps right into the small bowel. It's associated with nausea, vomiting, pain, cramping. And then I have this word here, the borborygmi, which is loud, hyperactive bowel sounds. Diarrhea, hypovolemia is common. Remember, signs of that would be tachycardia, tachypnea, orthostatic hypotension, dizziness, flushing of the cheeks, diaphoresis. Can cause pancreas to release excess insulin, causing that hypoglycemia. We want patients to be in recumbent or semi-recumbent position for 30 to 60 minutes after eating to promote slow emptying into the small intestine. So here's another slide on dumping syndrome. I went over a lot of that in the previous slide, so you can pause here and fill in what you need to about this. Treatments, like I said, the recumbent position or semi-recumbent position after eating. We want to promote small meals. We don't want people to drink when they eat. We want fluids to be done separately from solids. All right, stomach cancer. So this is an irregular growth of stomach cells. Risk factors. Some common facts. This is the second most common cancer in the world, but this is not widely seen in the United States a whole lot. H. pylori is mostly responsible for this, and then older adults are at more risk. Early or assessment findings that we'll have. Early satiety, which this is that feeling of full after just a couple of bites. Anorexia is common because, sometimes they have that dumping syndrome, so they don't want to eat. They're having stomach pain when they're eating. So anorexia is something that we see. Indigestion, just having that, their stomach doesn't feel good after eating. They may have some vomiting, and then ulcer-like pain that is unrelieved by antacids after a meal. And if these cells, they're going to be abnormal. They're not functioning like normal gastric lining cells, right? So they could be, more affected by the stomach secretions and not able to handle that acid and that kind of thing. So you got to think about, they're constantly getting pain with that. Diagnostics, EGD, so that tube down the throat with the camera, and then they can take samples with that camera as well. A CT and MRI might show it as well. Treatment is going to be a gastrectomy, and then probably some kind of chemo and radiation on top of that. All right, cholelithiasis. So this is stones that form inside the gallbladder or the bile duct systems. So risk factors, I have some down there. Women, older age, obesity, family history of gallstones, and use of oral contraceptives or estrogen therapy puts you at greater risk. Etiology, the stones are formed from cholesterol, bile pigments, and calcium salts. It can cause cholecystitis. So cholecystitis would be inflammation of the gallbladder. And then the gallbladder can get so stretched out and the walls so thinned from the pressure that it can become ischemic. And, we don't like the word ischemic because, ischemic means it's reversible, but lack of perfusion. And so if we don't resolve that, then we have tissue death, gallbladder attack, that kind of thing that happens. So assessment. Cholelithiasis can be asymptomatic. People can live with this their entire lives and not know that they have it. It can be something called biliary colic, where they have severe and steady pain after meals, which start in the upper right abdominal quadrant and radiates to the back of the shoulder. This is what I commonly see. Right upper abdominal quadrant pain with it wrapping around to the back. That's what people will talk about when they have this kind of gallbladder pain. Other times it can be seen as epigastric pain, just like right in the middle, like it's really bad heartburn. That was actually my symptom. So that can be a possibility as well. Acute cholecystitis has the same symptoms as biliary colic and lasts longer than 12 to 18 hours. So this is going to be up for a long time and not just after eating. They can have liver damage because, the bile duct systems are all connected there. So with that liver damage, you often see jaundice and will have liver pain. And if you guys remember where the liver's at, we're talking like the right upper quadrant area is where we're going to have that liver pain at. Pancreatitis is also something that we often see with this. For diagnostics, they can typically see these stones on ultrasound. Ultrasound is pretty minimally invasive test for determining this. A HIDA scan, this is a CT scan with a specific contrast and I think a little morphine to make the gallbladder a little bit angry. We look at white blood cell count for infection, ALT, AST for liver function. For treatment, we can do some dietary management depending on how significant the cholelithiasis problem is. But low-fat diet seems to work pretty well. It keeps the gallbladder contractions from happening because it releases bile to digest fat. Well, if you have a low-fat diet, then you're not going to have as much of that bile. Eating more high-fiber fruits and vegetables can help protect against cholecystitis, and you may need TPN during acute attacks where you just can't eat anything. Surgical repairs are going to be a cholecystectomy, which can be laparoscopic or open. These are minimally invasive if it's done laparoscopically. Typically, people are out the same day. Usually 1 to 5 small incisions across the abdomen, just depending on your anatomy and that kind of thing. And then remember those post-op